radiated ureters. If the bowel has been touched before, or chronic constipation, or Crohn's disease, or previous irradiation, and all these factors, you have to keep it in your mind before taking the decision of which technique of diversion can fit very well with good results in a particular patient. In addition to the existence of the facilities, like your experience, and the team is working around you, the nutrition, the stoma therapist, the ICU team, and all the nursing staff, in addition to the facilities in the theaters. Of course, all these factors are quite important to study and to explain to your patient which technique of diversion is good for you. So next, please. You have to stay next. You have to take enough time with your patient and to explain to him all the events that you will do for him, and what are the alternatives that can fit with him or not, and all the complications expected in the future, and how it would be the quality of life after a new bladder or a conduit or whatever it is. And you have to mention about the survival and the tumor relapse according to the risk factors. And of course, you have to include one or more of family members, because they would be a very good nurses for the patients in his life. Of course, if the patient is disabled or he needs some social support, of course, one or more of the family member has to attend this meeting. And of course, they have a lot of questions, and don't feel angry from a long story about their questions, because this is a decision of life. And if you don't take them in a very convincing way, I think there will be a lot of complications, at least many questions every day, and they will make your life not very easy from all telephone calls, or some problems happens and you didn't tell us about the continence and about the mucus and about whatever. So you have to explain, and you have to have a schedule for points of discussion. Even if the patient did not ask you, you have to give him its clear message that your life will be so and so after this sort of diversion. Next, please. Of course, for the orthotopic new bladder, the age itself is not absolute contraindication, because we are looking for the biological age and not for the chronological age. Sometimes we have patients with 75 years old and is more fit than a patient who is 50 years old because of some comorbidities. So the age as a number of years is not the matter. Patent functioning urethra, of course, free of tumors. Orthotopic could be offered to males and females with very restriction in selection criteria. Serum creatinine should be less than 1.7, and the clearance value of creatinine should be more than 60 ml per minute. And he has to have a healthy bowel profile, as well as motivated, compliant patient to accept such procedure, of course. Next, please. Look for some tumor factor for selection criteria. These two specimens of cystectomy I just carried out a couple of months ago for the right-hand side, but the left-hand side was 1.5 years ago. And you can see how much tumor inside in the bladder, and the patient were eager to receive orthotopic new bladder. Although in the left-hand side picture, we took a biopsy from the supramontanal prostatic urethra, and it was dysplasia and no frank tumor in this area. But the whole bladder mucosa was full of tumors. But on the other side here, you can see deep malignant ulcer, and in it penetrating even up to the perivesical fat, but the area of the prostatic urethra is quite nice and was free of disease. If we do a follow-up of these cases after 1 year, next, please. This is the patient with a multicentric bladder tumor after 8 months of the surgery. He has a bleeding per urethra and difficulty. You go by ureteroscope, you can find such a tumor recurrence in the urethra, and not only a single recurrence, but you see at the area of the proximal urethra close to the continence mechanism, there is a multiple papillary tumors affecting the urethra as well, and you can go in further advancement and to see that is still there is some growth. Is also it looks papillary, but it is exactly located on the area of the anastomosis, and it was even negative biopsy at the time. But the nature of the primary disease of the bladder tumor was telling us how much risk of this urethra to develop this urethral recurrence. What is the treatment of such a recurrence if it happens? Of course, if it is a limited number of disease. Next, please. No, next, yes. This is after we resected all the visible tumor. This is the area of the bladder neck. You can do that by laser coagulation or resection, or by very light current resectoscope, and all the visible tumor has been resected. But this is not the actual treatment really, because this patient came again after 4 months with another recurrences of this urethra. So it's better to avoid having orthotopic neobladder when there is a high risk of the disease to develop a recurrence in the urethra. Next, please. And we know when the tumor is risky, no, next. When the tumor is risky, the incidence of urethral recurrence is varied from 7 up to even 40% according to the involvement of the prostatic stroma. Of course, the art that we do in orthotopic neobladder, we use always 45 centimeter long segment is enough to give you a capacity of 450 mil at 3 months of follow-up. And take in your account that every 1 centimeter long segment of the bowel gives you after 3 months 10 milliliter capacity. So you need to have a bladder of 400, take 40, 500, take 50, and etc. So after detubularization and double folding with expansion of the wall of the new bladder, it can have a good capacity. If you use more than 45 centimeter, the risk of incomplete evacuation of this reservoir is high, much mucus secretion, and maybe significant residual urine, with, of course, consequences of retention, mucus secretion, stone formation, and, of course, bacterial infection. Hand sewing is very good in a single layer closure of the reservoir. The reservoir should be reconfigured into a spherical shape, because we know that the sphere gives you the maximum capacity from the least surface area to have minimal side effects of the metabolic acidosis, of course. Of course, anti-refluxive ureteric implantation is optional, but initially, when we followed the patient for short time, and this short time, I mean that 5 to 7 years, of course, there is no significant difference between non-refluxing and refluxing urethral implantation. But recently, and in this month, we collected with one of our colleagues to do MD thesis, and he could have 240 patients after 15 years of follow-up of orthotopic neobladder, and it has proved by evidence that those who had anti-refluxive technique showed more competent function of the kidneys if compared to the direct anastomosis with a short chimneys. But of course, the deterioration of the upper tract needs time, and this time now has been calculated for 10 years or more. You will find a difference, but not much patient will live for more than 10 years, of course, because of the aggressive disease. But I have to tell you that if you are able to do safe anti-reflux technique of urethral implantation and urine diversion without higher complication rate, please do that, especially if the patient is young age and the tumor of low stage. So because it is expected that this patient will live more and more years. Of course, you have to respect the preparation of urethral stump, not to have over diathermy, over sewing steps. And of course, this urethral stump should be very thick mounted by vasculature and adventitia around it. And don't violate the adventitia around the urethral stump to have more incidence of continence of urine. Of course, it should be dependent and funnel, and we use 6 stitches only in male patient and 8 in female patients when we have anastomosis of the pouch to the urethra. Next, please. Spherical configuration of the reservoir, whatever the technique you like to use, but it should be spherical as possible as you can. And 40 to 45 centimeters is good for the reservoir to give you 400 to 450 capacity. And dependent funnel urethral anastomosis is the keys of success of the good evacuation of this reservoir with a low pressure system, of course. Next, please. The attention of implantation of the ureter, usually the ureter is a very delicate structure and it may be skeletonized during the section or diathermy application around it. Please keep adequate adventitia, adequate fascia around the ureter and do a delicate dissection with no clipping by harsh instruments at all. We realized at the last few years when minimal invasive techniques came, high rate of stenosis of the lower ureters because of the graspers and absence of tactile feeling. When the graspers are crushing the lower end of the ureters, destroying the blood vessels, there is high rate of ischemia of these ureters. So please do vascularize the ureter. It should be long enough with no further dissection. You have to keep it, don't dissect more than you need. The anastomosis should be tension-free, direct mucosa to mucosa with nice spatulation. And if the ureter is normal, we use 5-0 sutures, absorbable, of course. And it is preferable to fix stents of 6 French siliconized, soft, multiple fenestrated stents to keep the minimum amount of leakage. If you follow such advices of urethral implantation, of course, and respect all these criteria of the technique, the incidence of stricture would be around 2.3%, at least in the experienced hand, of course. But when you feel that the stricture rate is higher than this, this is usually iatrogenic, and it is usually a sort of complication from the technical points of view. Next, please. We have to keep the ureter, nor if even we don't use an anti-reflux technique, the length of the ureter itself is working as anti-reflux because of its forward peristalsis. I did a very nice experimental work to compare the short ureter with the long ureter in having the right ureter very long and implanted both to pouch of low pressure system, and the left ureter in the animal has been cut close to the lower bowl of the kidney and replaced by Studer chimney. And we followed up these experimental dogs, and to see the reflux was evident on the left side because of the short ureter and was absent on the right side because of the long ureter. And of course, the 4 months IVU showed good excretion of contrast in both systems. But when we take a biopsy, next please, biopsy from